Good morning, everyone. This is Liz Stanley Salazar with California Institute for Behavioral Health Solutions. Thank you for joining us this morning. We are the Drug Medi-Cal Organized Delivery System Forum is presenting a webinar today, Designing and Administering a Unified Behavioral Health Program. We're very fortunate today to have two speakers from Pennsylvania who have many years of experience in implementing a managed care organization as well as a state system of managed care. When I started this project at the MC Forum, it was really clear to me that this was going to be one of the largest transitions, as it is to everyone else in the state of California, as we move towards managed care service delivery for our substance use disorder system. The waiver was approved by CMS in 2015, and I began attending meetings, and what became very clear to me early in the process was the diversity of counties, the diversity of their structure, their resources, the infrastructure, the population that each county serves is quite different, the stakeholders and partners that the county government worked with, both internal and external, and the providers that were currently providing services in the system, basically under the SAMHSA block grant in California. Many of these services were still provided under a cost reimbursement system. There's no shared risk. There's no consideration of shared risk. And so this gap, this movement to managed care system was enormous. And one of the questions that kept popping up in my mind was, is there someone out there who has done this? Is there a success story? Are there lessons to be learned? And sure enough, there are in Pennsylvania, because the state of Pennsylvania began the utilization of a managed care delivery system back in the mid-90s, 1997. So
20 years ago.
20 years ago. So we reached out, and Joan and Marvin will tell you more about this. I reached out to Pennsylvania, to Joan and to Marvin through the Center for Healthcare Strategies, and began a dialogue. Joan comes to us as the Chief Executive Officer of Community Behavioral Health, which is the MCO for Philadelphia, and she will speak about that. But what was the most interesting about Joan's history is she was the Director of the Office of Planning, Policy, and Innovation at SAMHSA, and also the Deputy Secretary for the Pennsylvania Office of Mental Health and Substance Use Disorder Services. Marvin is currently as the Deputy Director of the Office of Addiction Services, a division of the City of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. Marvin actually is the single county authority administrator in Philadelphia and has much to share with us about that system. So the Philadelphia system and the Pennsylvania system is a mature managed care system. And today we're going to hear about those lessons learned and the growth of the system and the development of the system. So with that, I would like to introduce Joan as our first speaker.
So good morning from Philadelphia, Pennsylvania. It's also Groundhog Day here in Pennsylvania. That's a long history. We are very, very hopeful that we were going to have a very short winter and a long summer. So keep an eye out for our groundhog. I wanted to make sure that we did a couple of things. One is Marvin and I want to just ground you a little bit in Pennsylvania and Philadelphia health choices so that you have some context for our conversation, because although there are extraordinary similarities between California and what you're proposing and what we've done in Pennsylvania, there are also some pretty distinct differences, and so we'll try to highlight those along the way. So if we can look at Philadelphia specifically, you know, it is our 5th largest city in the United States. It is a very diverse population, as you can see on the slide, 42% African American, Hispanic, and then we have many, many refugees, and this is a sanctuary city. We do also have, and unfortunately hold the highest number of individuals who are below the poverty line, and we actually have the poorest of the poor here in Philadelphia. So we have all of the things that are common in major urban centers. And as we think about the number of people who are uninsured, because of our state finally went to MA expansion after some period of time where they had chosen not to, that has reduced. We picked up over 100,000 new adults through the MA expansion here in Philadelphia, but our population is almost 600,000, so we have a significant Medicaid mix here in Pennsylvania. So
I would just also add, just to give you a sense that we're struggling with the opioid epidemic in Philadelphia, as I'm sure folks in California are. And, so for the last calendar year, we had almost 900 deaths from overdose. So, it's very timely to talk about the integration of these systems.
So if we look at Philadelphia's behavioral health system on the next slide, it is a single payer system, and it is the unique feature of having a carve-out and having the county really operate. It allows for blended and braided funding, and right now in Philadelphia, it is a $1 billion system that serves children, adults, and families, and we really have a birth to death. And our department includes substance use, mental health, and intellectual disability services. And we obviously have a range of services from hospitals to outpatient. Just a depiction on the next slide that really shows you what is really kind of interesting, again, about the way that Philadelphia structured its program is that the state had 3 options, and I'll go into this a little bit later when we go into the details of Health Choices, which is our Medicaid managed care carve-out program. But in Philadelphia, what they decided to do is kind of build their own. So from scratch, they made some early decisions about we can't do it with county staff because of limitations of civil service. So we will create a 501c3, but we will have it really led by county government. So if you look at our board of directors, the chair of our board of directors is also the commissioner for the Department of Behavioral Health and Intellectual Services. And then we have almost all it's always a majority county operated board of directors. Go next. I think you went the wrong way. There we go. So as I indicated, CBH is an administrative services organization, which means that the contract is between the state and the county/city of Philadelphia. They carry all the risk. We as CBH are an administrative services organization, which means that we carry all the functions. We do all the functions of a managed care company, but we don't actually have the risk. The other very unique feature is that we do not keep any assets here. So all of the money we save, both administratively through our admin resources as well as on the clinical medical side, all are able to be reinvested back into the community and are targeted towards mental health and substance use delivery systems. So it is this very unique opportunity to not really share any of our savings with a for-profit or for an entity that might, even as a not-for-profit, want to have additional reserves and savings. All of our savings go back into the city. We are required to have reserves and risk and contingency funds because we're really held to the same standards as a traditional MCO is. As you can see, I tried to highlight the fact that as of 2015, our membership reached 577,000. As we close out our calendar year of 2016, we have now exceeded 600,000 members.
And I would just add that as part of the expansion through, the Affordable Care Act, a lot of the new members are, showing, substance abuse, use needs. And, that's sort of been a higher penetration rate than, a lot of the earlier expansion of members.
So if we go to the next slide, it's really only to depict the fact that there is a physical health component. There is a choice of physical health plans in Pennsylvania's Health Choices program. A member is enrolled and they get to choose between typically 3 to 5 health plans. On the behavioral health side, and again, one key difference is that we have mental health, substance use, and some behavioral health services in our program. They are automatically enrolled with their county where they reside. So on the next slide, we really go back and try to always refer to what we are trying to accomplish in the program. I had the opportunity to be at the state during these first contracts, so it's been fun to see and interesting to watch 20 years later how far we have come in trying to meet these program goals, which still seem as pertinent as they were when we conceived them all those years ago. And it's to improve access, so we really feel as if access includes not only making sure that people have a clear pathway into services when they need them, at the time they need them, but also having a provider sufficient to make sure that it can really meet the diverse needs of the community. It's to improve the quality of health care, so really trying to raise the bar with our community agencies. And it also had the financial component, which was to try to stabilize the spending that was occurring and to be cost effective. Marvin's going to go ahead and talk a little bit about the county and the county's right of first opportunity.
You know, pre-health choices, Philadelphia County government, you know, has the legislative authority, programmatic authority, and the fiscal responsibility for both mental health and substance use delivery systems, and for establishing, you know, a provider network locally. So the county leadership includes a mental health, intellectual disabilities administrator, what we call a single county authority administrator, and in, I think actually similar to California, in the counties in Pennsylvania there are various versions, you know, of these authorities. So some single county authorities, the DNA authority, are what are called functional units, where they're actually providing some direct service, or they're doing the initial interview and referral and connection to the provider network. In other counties, for instance, Philadelphia, so in Philadelphia, Philadelphia is the city and it is the county. It's the same borders. In Philadelphia, we're purely an administrative unit and we contract out for services. But as you're probably aware in California and here, so the county government is also responsible for a variety of other human services, including child welfare, housing, homelessness, and an entire local court system. So just to give you a little bit more of a sense of this single county authority, you know, kind of responsibilities, you're probably familiar with the single state authority, the SSA. It's one for, you know, each state. In Philadelphia, you know, that's sort of been, in addition to the SSA, each county has a single county authority. So it's a way to localize decisions about funding, program development, and monitoring. So the single county authority is responsible for blending the federal substance use block grant funds, the state-based funds, and then we have two local, or not local, you know, statewide funding sources. State Act 152, which expands some of the coverage for people who are qualified for medical assistance, or Medi-Cal in your situation. And BHSI, which stands for Behavioral Health Special Initiative, which is a state funding stream specific to providing for the drug and alcohol needs for the uninsured or the underinsured. So the SEA also is responsible in some counties for the initial intake and assessment, and we use something called the Pennsylvania Client Placement Criteria, or the PCPC, which is really a variation on the ASAM. So statewide, everybody is, you know, needs to use the same level of care guidelines. So the SCA contracts for primary prevention in schools, community centers, early intervention, kind of intervening early, and as well as funding for treatment and recovery supports, including recovery housing and some gambling initiatives. What's that?
Mm-hmm. Go to the next slide.
Okay. Is that me or is that you? Oh.
In the Health Choices program overall, as indicated, similar to what I understand is the situation in California, is there are all shapes and sizes to our counties. And so we are going back and forth and giving you, again, context of the bigger Health Choices program and then trying to focus on Philadelphia specifically. But there were different options that counties could employ. As we indicated in Philadelphia, we developed our own behavioral health organization. Many counties will hire one of the major plans like Magellan, Value, etc., and they can hire them for either administrative services or they can actually download the risk. So again, the relationship continues to stay with the county and the state in all but instances where the county might have opted out. But the county does have the opportunity to download risk if they want to subcontract with a managed care organization that can actually assume risk. And in that case, those organizations are then covered by other department regulations like the Department of Insurance and the Department of Health, who can oversee those kinds of entities. And then again, reinvestment becomes available, and it is limited. One of the big fights we had early on in Pennsylvania was counties indicating, well, if we're going to assume the risk, we also would like to use those reinvestment funds to pave roads and pay for other kinds of administrative infrastructure. And one of the things that both CMS and the state agreed, and certainly the behavioral health authorities in the counties agreed to, is reinvestment and savings could only be used for behavioral health purposes. So that's been a real benefit to both the state generally and to Philadelphia specifically.
So, another, kind of ripple in Pennsylvania is that there are a number of counties that are, let's say, joinder counties, or are, working together, with the, behavioral health plan.
Right.
And so in some of them, there are as large as maybe 20 counties working together. And other counties opted to, go it alone. So there are some variations for, food for thought for California.
Right. If you go to the next slide, it really depicts what Marvin just highlighted, which is these are the zones that Pennsylvania created. And it took us 10 years to really fully cover Pennsylvania. Philadelphia and the surrounding counties in the light blue were the first to come up. So we have the benefit of 20 years, and I will say that we just celebrated yesterday, because the first day of services was in 1997 on February 1st. And again, it took the state 10 years to actually raise it up. Where it says the North Central state option, as Marvin pointed out, those are all counties that said we really don't have enough Medicaid lives in our communities, and our counties are too challenged by taking on any of this responsibility. So there is a direct relationship and there's a direct contract between the state and the managed care organization. However, that MCO has a county advisory that has both the mental health administrators and the single county authorities from all of those counties, and they actually make all their decisions collectively. So it has really worked out that county government has had a key role irrespective of what the model has been. So if you want to go to the next slide. Again, just a couple of other key elements in Pennsylvania generally. It was the county right of first opportunity, again, was something that was really controversial for CMS initially, because we had to argue for a sole source contract, and we had to assure CMS that the counties were equipped. And so all counties had to actually respond to an RFP, and there was a rigor around a readiness review process. What did also occur is the provider, instead of having a choice of a MCO, there was a requirement to have a choice of providers. So in the initial year, all Medicaid providers, any willing provider does come into the program. After that, you can start to limit the provider pool, and there's a choice of 2 providers at each level of care. I understand there are some providers on the line, and I only want to reassure you, I worked for the Providers Association and actually helped build an MCO on their behalf years ago. What we have found in Philadelphia, really, and across the state, is that you actually need more providers, and providers have really benefited under the managed care environment. And it is very rare that you see, at least certainly in Philadelphia, that we are eliminating any providers or access, because we truly need more, not less. In Pennsylvania, again, one of the things that was an early decision is that all state and federal eligibility categories came in, so there's no carve-out for children who might be dependent or delinquent. There's no carve-out of any kind of population or eligibility category. Instead, everybody's in. The only exclusion is if you are in a nursing home for over a month, you are then back to fee-for-service. And clearly we still, because we have a 1915B instead of what I understand you're going to have as an 1115, so we still are not able to pay for folks in jails or things like that, although we have covered IMDs. We also include some children's services for children with intellectual disabilities, and we cover autism in our program. Do you want to go to the next slide? The other thing that is, again, something to think about, and this will be perhaps something that California will want to focus on, is who pays for the pharmacy benefits. Early in the program, that was a major decision point about how we would carve out pharmacy benefits. So right now, the pharmacy benefit, with the exception of methadone, is covered by the physical health plans. And so things like buprenorphine and access to those kinds of things are all paid for by the physical health plan, and we have had to work hard to have a relationship with them in order to make sure that we can do the right thing and have access to that.
As well as Vivitrol.
Right. It includes all the state plan services, and we'll talk a little bit more about that. One thing to consider that actually the advocates have found very helpful is we have something called a consumer family satisfaction team that is both for mental health and substance use, and it has individuals with lived experience and their family actually being part of the quality management structure for our program. In Philadelphia, we have a very, very live and vocal consumer family satisfaction team that goes out and interviews members on a regular basis and gives that feedback to county government.
So they're going to provider waiting rooms. They're talking to folks who are, waiting for treatment or coming out of treatment, and they're asking them about their experience, and they're, kind of writing up complaints, and they're sending it to kind of senior leadership.
And as I mentioned previously, there is reinvestment available, and then there is a requirement for a performance measurement system, and we'll talk a little bit about that later. It's, in Philadelphia, we call that P for P. So if you want to go to the next slide, please. Marvin's going to highlight the services that we currently cover.
So we cover in-plan services that are in-plan as part of the state plan, MA plan, and part of our plan includes the local state Act 152, which pays for non-hospital detox, rehab, and halfway houses. The in-plan also includes inpatient drug and alcohol detoxification, non-hospital residential detoxification, rehabilitation, halfway houses, and outpatient drug and alcohol services, including medication-assisted treatment, methadone, lab work, and part of our obligation is crisis services. So that would be, we have a network of crisis response centers, 24/7 telephone access and response, and a mobile emergency teams that are able to be dispatched and see people anywhere in the city. The supplemental services, services that are not part of the MA plan, but services that we pay for as supplemental services include adult partial hospitalization services and mental health partialization services, recovery specialists, peers, and we have some special arrangements for substance abuse case management and substance abuse forensic case management, as well as intensive outpatient or IOP. Locally, we have quite an investment with what we call our forensic intensive recovery, or our diversion and early release from the county jail system into the community, and a pretty well developed series of behavioral health initiatives that interface with justice, a range of problem-solving courts, and special assessment and ongoing case management services for folks who are reentering the community. And I would say that part of the challenge with the system is really blending the different funding streams, to be clear about who's paying for what. For instance, I mentioned earlier that we're paying for some recovery support services that are not in plan and that are not supplemental services. And for example, a network of recovery housing that's closely linked with our forensic reentry population. And that's sort of been one of our challenges from the beginning, and something that we kind of continually need to work out. The other funding stream that I had mentioned earlier is the BHSI funding stream, which is specifically for the uninsured, and in a very direct respect, this is a way for the uninsured to enter the system, and it really increases access to the expanded MA coverage. And we have worked hard to make the same criteria and to make that transition from BHSI to MA coverage seamless, particularly seamless for the individual seeking help, whereas behind the scenes we work out the finances.
Okay. We wanted to next go into some of the financial overview, just the basics. So it's a managed care program, so we are paid on a per member per month. The city is at risk for the overages. One thing that I would say you want to argue perhaps with your state is that initially the cities and the counties were permitted to keep all of the savings. In most recent years, the state has capped that. So I think there is certainly an argument to be had until you really get grounded in managed care, until you really understand how it's going to impact your community. You really want all of those savings to be available. But currently, we are capped at 3%. The capitation payments are required to be actuarially sound, and the feds will look at, and the state will look at us to see whether or not we are efficient and well operated. Interestingly, even 20 years later, providers are paid on a fee-for-service basis. We are permitted, and we do from time to time pay alternative payment arrangements, which could be bundled and per diem, etc. However, the state and federal requirements still demand that providers give you encounter data in really minute detail, so it was somewhat onerous for providers to be able to actually do the kinds of things that needed to happen. But I would say, again, another lesson learned and things to think about is during startup, fee-for-service, if that's what your agencies are accustomed to, you want to try to keep that in place. But over time, looking at how it is you can do different value-based payments and bundled payments is an opportunity once you become a little bit more mature.
Okay, next. Okay, we're at the poll number 1. We'd ask all of the attendees to take a look at this, and we'll give you a minute or two to complete this, but we would ask you to do that. What do you believe will be your greatest challenge moving into the managed care environment? If you could select one of these, we will share that information. Okay, here we go. So in answer to this poll, overwhelmingly, the responses are managing, I'll go backwards, managing implementation with existing resources, integrating with existing system of care, making services accessible to the members. Seems to be the least problematic. Okay, so let's go to answering some of the questions that we've received. Thank you for responding to the poll. I'm going to, let's jump in with some. We have a couple of detailed questions, and they, they range across the board under program, administrative, clinical. So one of the first things I'll ask you to do, since you just talked about it, Marvin, could you talk about the substance abuse case management service? Is it a part of your waiver? Is it supplemental? How is it a benefit, and how is it paid?
So it's a supplemental service, and so it needed to be approved by the state, and get the the MA promise number, and initially we're still paying for case management for the uninsured. But what this allows is, once they convert to MA coverage, then the local managed care entity, picks up on a fee-for-service basis, as Joan says, all the billable services. So, this is the part that, we look to make, sort of invisible to, the individuals receiving the service is, if they need the service, and they're a resident, we're looking to provide it and then work out a little bit after the fact how they get paid. And, that's pretty challenging, but, that's part of, the blended or the braided approach to, providing services and supporting the delivery system so that they're not, really taking a loss, but able to serve not only the MA population, but the population in need.
So as a supplemental service, it is a benefit for anyone. It's been approved by legislature to be a benefit for anyone who is eligible for the MA services.
Yes.
I have a question. How you talked about fee-for-service for the providers, and that in fact is how California providers will be reimbursed. How were those rates established? I mean, how did you construct your benefit package? And you talked about extensive encounter data. Are you requiring annual cost reports of your members or of your providers? And how do you adjust your rates? Is it annual? Explain that to the audience.
So this is Joan. Let me take a shot at it, and we'll have Marvin add in. So when we start the program, as the program gets started, the rates are really, the capitation rate incorporates the fee-for-service rates that were paid to providers prior to the managed care implementation. So you start out very similar to what you would have expected otherwise, because that's what the Medicaid program is grounded in. So rates really didn't significantly change. However, what we were able to do, and certainly have done in Philadelphia, is based on cost of living challenges, based on our expectations of agencies, based on reviews of agencies, and really what our priorities are, we have certainly adjusted rates over time. The state capitation would say, and the state folks would say in Pennsylvania, that they try to include an adjustment for cost and utilization, which they assume could get passed on to the providers on an annual basis. Honestly, that doesn't happen, and it doesn't happen in any county that I'm familiar with, that there is an annual kind of cost of living adjustment. It tends to happen two ways. One is we as an MCO have to have a rate setting policy that is very clearly written and articulated to providers. So if a provider wants a rate adjustment, they need to come in and kind of make their case. And at that point in time, we would not ask for a cost report. What we would ask for is their updated financials. What is the program that they're actually asking for? What's the justification of why they want a rate adjustment, etc. And then that's really a negotiation. Most of our rates are pretty standard. So for many of the community-based services, the case management rate, for example, is the same rate, and it's the same rate in the county. So one of the things that we do is that we have the same rate for the county, non-insured, uninsured, as well as for the Medicaid population. We do not ask for an annual audit, although the county does, but the Health Choices program does not. Again, what we really look for are opportunities. For example, this past year, we had some additional revenues, and so we made some adjustments to rate. And then we also have something called pay for performance, which is a only upside performance incentive payment to meet certain benchmarks. And that can really average for agencies based on what their revenue is for us. So there's multiple kind of avenues into both thinking through what you want to prioritize, how you want to pay your providers, and what kind of rate structure you want.
So I would just add to that Joan mentioned the kind of reinvestment, what would, in another system be considered profits that we're reinvesting into, the service system. And periodically we've identified additional service needs, and we've used reinvestment to start up a new program. And during that startup time, we have allowed the agency, with an improved scope of service, to show us their actual costs. And we've allowed it to run for a period of time. It might be 6 months, it might even be a year. And, then there is enough data to convert that, cost information to a rate that will, cover the actual costs. And so we'll use that kind of a joint process and interface with the county and the managed care organization to develop new things and then to move those things into either in-plan or supplemental service. Does that give you a...
Yes, that's very exciting that you use your reinvestment funds to ramp up or start up programs. It's part of the struggle that's going on here in California. There are several questions about the, well, let's stay on the administrative and financial for a second. So you have this remarkable integration of multiple service systems, and as you can see from the poll, 40% of the attendees, consider that a challenge. Did that exist? Give us a little bit of that development, because is it the umbrella organization? Did you have that umbrella, that close integration 20 years ago? I'm sure there have been changes. How difficult was it to do these projects jointly? at the county level. I'm assuming there are single state authorities in each one of these systems in Harrisburg.
So let me say a little bit about the state picture, and then certainly Marvin can talk locally. And I think it's some of what we try to attend to later on in the presentation about decision points that counties should be thinking about. So the first issue is that in Pennsylvania, the state authority is not in the same agency as the Medicaid authority. And that did create challenges from the beginning. Although it is administered by the state authority that has the Medicaid and by the Mental Health and Substance Use Agency within that, there is an outside state authority for drug and alcohol and the block grant, and that has plagued us over the course of the 20 years. It has also been where rules, Pennsylvania has a stricter confidentiality rule than the federal rule. And that has also been an area where that state authority has taken a leadership role in trying to maintain that, and that again has had some tension. So we've really grown national advocates around that issue, and it's been a challenge for us. So there were definitely challenges early on around substance use. At the local level, I think there were early decisions about how the county role was going to operate. In almost all the counties from the state side where they took on the authority, they made sure that no matter what the configuration was, they had both mental health and substance use county government in the oversight role. And they either developed their own, in some counties they actually developed an oversight entity that was sitting outside of government again, to oversee the program. So, for example, if they contracted with a private MCO, they wanted to have oversight, but they've always had mental health and substance use. I think decision points are around what we've done in Philadelphia, which is we are an integral part of the county. And so we have all of the practices around assessment, around access, any policy decision that's made is all done collectively and we all adhere to it. The rates are the same, etc. But it definitely didn't start that way, and it had to build some, you have to build some confidence in how it's going to flow over time.
So going back 20 years and actually continuing, there were a series of, forums, planning meetings that, involved, the county authorities, and the people who were, gearing up for the managed care organization. And, both places actually reported to the same person. So there was a certain amount of, head knocking and endless meetings, endless, I say. Some meetings at 7:30 in the morning. And I think, what evolved from that was, some relationship building, some understanding and thinking through a lot of these, tough issues about, the roles and responsibilities and, what protocols will be used, and, a lot of detail around the, the braiding of funds and, what will pay for what. So, for instance, at the beginning, the SCA, or the Drug and Alcohol Authority, used to pay directly for residential treatment.
Right.
And, once, CBH was up and running, that was a conscious decision that, well, there's no longer a need to pay for that. That's going to be an in-plan service or a supplemental service. And, therefore, if we're going to pay for service, we're only going to pay for the uninsured. And we're going to work to convert people as quickly as possible so they can, benefit by a broader range of behavioral health services.
So I guess at the other, I mean,
there's a question on that, Joan. When you talk about graded services and on the, I think what I could say fairly in California is there's a lot of blended or blending of programming and at the provider level, what happens in terms of as the funds move outward from there, in terms of what efficiencies have you achieved in credentialing applications across these systems, or audit reports? You said that there were not audits required of the year-end audits required of providers. What is the monitoring process? What is the auditing process that does occur as these funds separate and go up their different channels? And who takes on that responsibility?
So there are still kind of multiple checks and balances. And one of the things that Philadelphia did is they created something called NIAC, which is a network of accountability structure that really their oversight of an agency is really on the programmatic side, but extends into Health Choices credentialing. So it's only one touch that has to happen at an agency level. It's more comprehensive. It has individuals with lived experience. There's interviews on every segment of the organization, and they actually present their findings to the CBH Board of Directors, and that credential holds true for both the county side and the Health Choices side. So that's been definitely one efficiency and something that agencies asked for because there were multiple people involved in their lives from the county side. That still, though, does not negate the fact that the state has a role in licensing and continues to have that monitoring. On the financial side, there are Medicaid rules about the financial side that definitely do not go away in Health Choice and in fact are scrutinized even further, and that's really around compliance. So although if there is an indication that there is a challenge at a particular agency, then our compliance staff will network with the other county staff that might be involved with that program, and we will go out and do joint audits. We have gone out and looked at charts, we have looked at financial information, but have done that as either a concern or a complaint comes up. We do routine compliance audits all the time. But it really does come up if there's an issue, but we are always in lockstep with the county in trying to interface with an agency that may be having problems. There is also, the county still has obligations with every funding stream to the state. So on the Medicaid side, agencies, when they submit their claim to us, that has the encounter record attached, and then that is a reporting that we do to the state. We compile all the information, and we have financial reporting on a monthly basis up to the state. It's monthly, quarterly, annually, etc., and we have our own audit. The county, on the county side, also has an audit trail, so their funding also is reviewed both on the mental health and substance use side, and they have a reporting structure back up to the state. So there's accountability links, really throughout the system. You have to be able to still unbundle, like if you're going to braid the funding, and I think substance use is much more adept at this than any other system because there's so many multiple sources. It's really at the county level you unpack it and then you report it. So, for example, a person comes in, they're uninsured, and then they flip to Medicaid. At the time, really those things happen. You want it to be blind to the consumer or to the member. The agency, we, as the county and the Medicaid authority, we at times have to back money in and out, but we always make the agency whole. But we do have to account for every dollar built back up to the state system.
So, just picking up and going back to the monitoring. So what we have evolved over time, is really an integrated monitoring team that involves, personnel on the county budget, as well as personnel from the managed care organization. And they go out, together. On the drug and alcohol side, there is sort of a mandatory monitoring tool that has to be administered, from the state, single state authority. And that's integrated into, what we call this NIAC process. And whereas the integrated monitoring team may go out and monitor a whole agency-wide, either annually, every 2 years, or even every 3 years. On the drug and alcohol side, the requirement is for an annual monitoring visit. So, we've worked out in, kind of internal protocols to make sure that we're meeting the mandate from the Drug and Alcohol Authority as well as the Medical Assistance Authority. And, I was actually joking with Joan, yesterday that for quite a while we had several grievance procedures, one for one state entity and one for another state entity, and that was one of the challenges of the, blended, finances was, well, what is the grievance procedure for individuals? And, it ended up being they had two different, grievance procedures that we had to make single behind the scenes. So there are challenges, and there is a lot of work, and there is like evolution over time.
All right, that's very thorough. You're going to have to keep going, Marvin, because we're going to move to the next slide, and the slide number 20 is yours to take up.
It is.
I think this is mine, and then Marvin does the next one. So this is Joan. That's okay. Just things to think of during your startup is one of the things that the counties want to really be clear about is what does the waiver say? And although that's a state obligation, it's important to understand what, in fact, the waiver obligations are and things that the federal government and or your state is committing to. The other opportunity is to, again, establish the roles and responsibilities of the county authority and whoever you're going to have doing your managed care functions. Something to consider really at startup that was a major component for the state and certainly for Philadelphia was readiness review, is that there was an extensive process about how to decide whether county government was ready to launch. And that every part of the system had to test itself, predominantly making sure that your MCO can pay a claim, and that the providers know how to bill a claim. Things that are really foundational to managed care are really important during ramp up to try to get resolved and confirm that you have the infrastructure to do it. The other thing you may want to consider early on are early warning systems. So at the state level and here in Philadelphia, at the ramp up, started to look for indicators about how do you know if it's going okay. So in the first 30 days or the first 60 days or the first 90 days, you don't want a major mishap. So there were weekly calls and then monthly calls and then quarterly calls. But there were indicators of, from the systems perspective, about, things that could have been going awry. So, for example, we'd look at authorizations of services. So if prior to your managed care program, you were doing 100 authorizations for non-hospital residential, and all of a sudden you only see there's 50 authorizations, you're thinking, well, something might be going awry. Or, for example, in the mental health side, we would look at 302 emergency commitments and looked for whether or not they were, they were increasing. So you can do all kinds of benchmarks, keep them simple, but keep them as available ideas to say, things are going either smoothly or not. And also certainly having a lot of feedback from your members. So, the consumers, we set up places where they could call so that we could problem solve and troubleshoot immediately at the county level if, in fact, they were having any difficulty in accessing services.
I would just add, one of the early decisions, about this implementation was that we contracted with any willing provider. In other words, we took the existing provider network, and if people wanted to be part of it, then there was no barrier. And, that had, I believe early political ramifications, and, it wasn't like we were, at least at the beginning, having barriers for or criteria about who could join the network. If they were already part of the network, then they were automatically part of the network. And each county probably has to sort of look at that and decide, kind of what's best for, their local continuation.
I think on the next slide, I'll do a little bit in the beginning, and then Marvin will do that slide in 22. But I think one of the things to consider, again, just reiterating the fact that you want to understand your waiver design, but more importantly, as a county authority, what is the vision and what are you expecting to have happen? So one of the things that we think is really extraordinarily unique, of course, about Philadelphia is that it was all vision and mission driven. And although money was obviously a key component and savings needed to occur from the state level, it was all about making sure people had access to services and that it was a do no harm, that this was going to be a perspective where you were not, and we were not, going to ever do anything that was going to actually compromise individuals in being able to access care. And so there was really strong county leadership here at the time. Obviously, Marvin was one of those leaders who I think really held everybody's feet to the fire that this was not going to be about denying services or only going to the lowest common denominator. This was really going to be about building a system of support and service so that everyone could find their path to recovery. And I think it is important to articulate that so that your community knows that that's the reason you're doing managed care, or at least if you are being required to do managed care, this is what you're hoping and hopeful that the outcome will be.
Some of that was, I think, our experience back then with, HMOs at the time was that a lot of time their response was just say no, to particularly behavioral health services. And so as Joan says, the kind of the mission and the vision was pretty clear early on that we were going to be, doing, what people needed, and over time we're going to take, and closely monitor the expenses and make sure that, what we were doing was going to have cost savings, and, hopefully we get to it, there were significant cost savings that really benefited the system. I don't know what that is.
If you want to go to the next slide.
Okay. So, so I mentioned that, a key consideration is the existing provider network. And, how will that existing provider network be integrated with the new managed care organization, the county infrastructure, what will the, kind of responsibilities and roles look like? And, as far as the county, we have existing relationships with other county departments and other related systems of care. And, one of the benefits is sort of bringing those over, and the letters of agreement that, need to be in place or need to be put in place for, this development of this new system of care. The other example that, both Joan and I spoke about was the, the monitoring, the NIAC, the integrated monitoring team. I don't think we need to say any more about that. And the financial, management and the kind of the joint rate setting and the, kind of hand-in-hand startup and then, carrying through for sustainability.
And then I think in that final bullet, it was really intended to, again, as you can hear, there's lots of themes to reinforce, is really taking a serious look at the county staff about how it is you do want to monitor. So in Philadelphia, again, the county staff and the MCO, because they created their own, really work hand in hand, and the monitoring is done collectively. In other counties, they have really looked to create a outside entity or even hire an individual to do the monitoring, because it does take some additional financial capability, access to clinical folks, quality management. These are all the components that you want to be considering when you think about what the county role might be in assuming the responsibility.
Should we need to just go to lessons?
Yeah, we can move to lessons learned if you would like, which would be
we still have Joan, we still have time. We have
okay.
Okay.
You don't have to rush yet. We're
Okay, all right.
Oh.
Thank you. Okay, so on the MCO functions, on slide 23, I think as you heard, kind of again as a theme, is what do you want the county to function to assume, and what are you asking your ACO or your MCO to assume? Again, thinking through that if the county actually currently performs any kind of clinical services or assessment, or what are they doing in your system? As Marvin used examples of, and in residential, we were paying for that, we're now shifting that over. So it's really important to have those kinds of conversations. The other thing is that how will you split the administrative costs? So the dollars come from the state to the city, and the city does take a portion of those dollars and uses it administratively because they recognize that county staff are actually allocated to the program, and so they can cost allocate Medicaid dollars and use the Health Choices Managed Care program to pay for some of the county employees. And that's really, again, been a benefit to the city county. Another really key area that requires some thinking is the 24/7 capabilities. So CVH actually answers phone calls 24/7 on behalf of insured or uninsured. And that was an early decision point, although the substance use system also has a phone number for some authorizations for non-hospital, but we do try to make it seamless so that irrespective of what you call, you can transfer as a warm handoff so that folks can get what they need. But you want to make sure that you're making a conscious decision about how do you want your existing emergency service to operate. Same thing similar with information and referral, community outreach and engagement. How do you want that to happen? Do you want really that to be downloaded as an MCO function, or are there things that the county really feels strongly that they need to control? I would say one of the things that you want to think about from the provider contracting side, and for those of you who are providers on the phone, one of the things that can happen at times is that the provider will use some political leverage perhaps with the county if the managed care organization isn't treating them well, or they perceive they're not treating them well. One of the things you want to think about as a county is really being in lockstep and having control over how it is those provider issues are resolved. So what we do if there is a challenge with a particular agency or there is a dispute, we really try to come together and say, let's work it all out collaboratively, as opposed to trying to kind of separate and use one another against each other.
Plus, we've always, used the RFP process for new providers to, have everybody, have a level, playing field, and, kind of earlier on, sometimes there was some more of like who you knew, to get a contract. I'm sure that doesn't happen in California, but
just in case,
yeah.
Right?
But that's another sort of protection for both the county and for the MCO, is to go through a transparent, legitimate process, objective, for program expansion.
Really thinking through, again, what role the county will take in quality management and complaints and grievances. In Philadelphia, the complaints and grievance process rests with CBH, but we also bring in for second level county staff at times to negotiate complaints and grievances. Clearly, one of the major components is having data systems and being able to report. And again, you want to think through who's got the data system and how to do an integrated data system so that you can really report out and understand the experience. I would say that 20 years later, we're still working on data systems and integration of data, And particularly because of the sensitivity of substance use information, it's how do you put those protections in that maintain the confidentiality of those of our members, but also still give you an opportunity to do decision support around how you want your system to develop. Another key issue is claims payment. You clearly want your MCO to be able to pay a claim. And this is an area, again, where providers have struggled. And I don't know if it's true in California. Obviously, it's 20 years later, so it sounds like providers may have already had a lot of experience in the fee-for-service system. And if that's true, it may not be a leap. But it was a struggle here where providers didn't know necessarily how to get, how to obtain an authorization and how to submit a claim to the MCO. And so, really making an investment with your providers and your provider organizations to really set up lots of training, lots of opportunity for problem solving. One of the things that can happen is that agencies may feel as if they don't want to raise up concerns with their major payer, the county. And so in the early days, providers actually would be silent and not raising up the fact that they weren't getting money because they weren't getting claims paid. So you really want to have lots of vehicles and lots of openness about the expectation is that the agency's getting paid. You want them to be paid. You want them to be paid in a timely basis. And if they are really having a difficulty with an authorization or a claim, that there's a troubleshooting and there's a remedy for that, that is really timely and available to the agencies.
I would say, one of the other pluses for providers is that they get paid much quicker from the managed care organization than they were from the county or the city. I'm sure that's different in California, but the city is historically slow to pay, and that's really a burden on smaller provider agencies.
And if we go to the next slide, just to add another, again, reiterate that in our program in Philadelphia and across the state, it was really important to have individuals with lived experience and advocates and families at every level. So they participated in the readiness review at the startup of the program. They drive the consumer family satisfaction team. They sit on all the advisory committees. And it was really important for us to have a group of advocates and members who understood the problem and also could help others in troubleshooting. They also sit on any of our RFP selections. So we always have someone with lived experience or a family member really making the selections. And it has been a tremendous benefit to have that voice and have it be alive and well, because they often can identify concerns before we get to know them.
And we've also strongly encouraged providers to make sure that on their boards are, recipients of service or former recipients of service, so that, at every level, including, as Joe mentioned, the RFP review process, we've included people who are recipients of services.
And then we thought it might be worthwhile just, kind of lessons learned from both Philadelphia and generally is just to recognize, without a doubt, there are always bumps. In reminiscing about our 20-year history and our celebration, many of those bumps surfaced as we were reminiscing about how CBH started and how the Health Choices program started. One really quick story is that the 1-800 number that CBH in Philadelphia assigned for the program so that you could have members call in, the state had gotten the number wrong, or they thought it was wrong, and they changed the number. And so you had at that time, 400,000 individuals calling a number which unfortunately turned out to be a site that was of ill repute. It was one of those lessons learned about detail and how it is that you really need to be attentive to making sure that things are set up so folks can come into the program with ease. Communication and quick deployment are the keys to success. So troubleshooting and really being able to identify problems, having members and individuals with lived experiences, as we referenced, and the fact that providers do need support based on, you know, their level of expertise and experience with managed care. For agencies who are more sophisticated and have commercial contracts or who have been working with managed care, the transition isn't as challenging. But we found in Philadelphia, we had really predominantly public sector, very traditional community mental health centers and substance use agencies who were accustomed to county payments. And so it did take some time and an absolute commitment to make sure that they were okay.
Including some kind of targeted TA for some of the you know, smaller providers who, you know, just needed more help to, you know, be able to, you know, kind of achieve all the expectations, you know, including the you know, electronic billing and, you know, a higher level of accountability than they may have been used to before.
And hopefully it won't take you as long as it has us to get to the fun stuff. So someone said to us early on, you know, it does take a while for a program to mature and for you to be able to see success. And so the comment about keeping to the basics is that in year one, it really is making sure your infrastructure is sound. Again, kind of do no harm, make sure that you're really trying to pay a claim, get an authorization, have opportunities for input and troubleshoot, and a strong monitoring strategy to at least get yourselves off the ground. And then there really is light at the end of the tunnel, which is really what we thought we could end with on as a highlight.
Okay, a couple questions. Let's say focused on the provider arena, because you just hearkened back to it in your lessons learned. But right now, many counties are facing the simple fact that the providers some providers are experienced, as you know, and very experienced in managed care or in commercial insurance or in fee-for-service contracts, but many in California are not. And we also come from a traditional substance use disorder approach, so we're just now implementing ASAM, and we are just now implementing a benefit structure with defined levels of care. What you spoke very much about, you know, do no harm. What was your own experience, maybe not so much in Philadelphia, but across the state? What was the experience with the capacity of providers to make this transition, and give a little bit more detail on how you assisted them?
So I can start, and again, Marvin can talk about Philadelphia specifically. I would say overwhelmingly, we didn't lose many providers at all. And I, you know, again, the intent is for providers to survive this, and that they really can thrive and be financially stable as the time goes on. And so that the experience overall, and I think if the agencies who are on the line want to check in with the trade association here in Pennsylvania, I do think that, or here in Philadelphia for that matter, I think they would share with you probably, I think they would really echo what Marvin and I have been saying, is that there are some bumps and you have to attend to them, but agencies really have been okay in this managed care environment and in many instances have thrived. So we didn't lose agencies to the fact that they couldn't bill and they couldn't, because you just keep working with them. And it really depended on the model. Counties really used their managed care organizations, and in their contracts would say, you know, we're expecting you to have so many trainings. We're expecting you to have, you know, a problem-solving mechanism where there is an immediate response to a TA. We want you to make sure that you are sharing the information with agencies that they need. And all of them did. And certainly in Philadelphia, there was lots of ways that the trade associations locally also, came together with the county and CBH to say, let's find forums where we can troubleshoot and have these conversations about how the claims payment would work.
So
in California, providers must receive a clinic certification, drug Medi-Cal clinic certification, or program certification from the State Department. And is there a similar process in Pennsylvania?
Yeah, the state of Pennsylvania licenses all drug and alcohol programs, and has licensing requirements. They visit annually, and on the mental health side, the state authority licensed those programs. I would just go back to kind of a very early decision point where here we made the decision to work with any willing provider, and kind of reassuring people that again, it wasn't only about saving money; it was about providing appropriate, adequate care, and working with folks, as Joan says. And we had lots of meetings, lots of training, and we still have targeted TA to agencies that are struggling with maybe new agencies, with what's expected and how to bill properly. So I don't think there's any shortcut for that stuff.
No, but it sounds to me like your licensing is also the authorization to bill Medi-Cal.
Yes.
Yes.
Yeah, the Health Choices RFP, or the contract from the state to the city, or state to the county, really lays out those kinds of requirements and says any agency that we're using that can be licensed through the state has to be licensed. So that authority is still in place.
Okay. The next question is about your use of peers in your system, and you mentioned that peer support, or peer recovery support, was a benefit. Do you have a certification program, and was that achieved through your waiver or your state plan?
So it's both. Right now there is a mental health and a certified peer specialist. That can also extend to co-occurring mental health and substance use and specialties around forensics, etc. That is actually in the state Medicaid plan. Unfortunately, they did not anticipate, and it had not included a certified recovery specialist that was drug and alcohol only. That has to come in as a supplemental service, and we are actually just bringing it in as a supplemental service, although we have utilized peers and certainly have stretched the co-occurring capable pretty far here in Philadelphia.
And we do have local training programs for the peers to go through and get a certificate. And at the state level, there is sort of a state level certificate that folks can also get and qualify for, and we use that as a criteria for filling peer positions.
It also sounded like you mentioned penetration early in your presentation, and that the expansion population, the growth in demand for service was a bit unexpected. That was the takeaway that I had. Is there anything you can say about your outreach or your effort to, have you had difficulties or challenges in encouraging people and engaging individuals in treatment? What successes have you had in that area?
So I think with the MA expansion, really a lot of people who now had coverage, felt a little more liberated to seek help, to get treatment, and these are people who maybe were suffering silently before. I think the other thing that sort of is happening, over the last, few years, sort of one of those unfortunate perfect storms is the, opioid epidemic, and the sort of fueled by the, prescription, opioids, some questionable prescribing practices that are, now changing, and the conversion to what in Philadelphia is some of the cheapest and purest heroin on the East Coast. So, those are part of the reasons that more people were, looking to get into treatment, coinciding with the MA expansion going back, like 2 years ago. Yeah.
And
Do
then,
you have any? Go ahead, Joan.
no, I was just going to say, and there really is a pretty extensive outreach. Again, this is one of the things where you can marry the resources, is that the county funds a homeless and housing resource and outreach team, and has like telephonic outreach through the county system. And then we have staff who actually go out on site with the county staff to, it's a location called Prevention Point. It's really where there's a needle exchange and where there is a high number of individuals who have substance use and opioid addiction. So we actually put staff on site collectively, so whether you have insurance or not, or your Medicaid, we can authorize services at that location immediately to offer immediate access, and we're definitely starting to see the fruits of that.
And we sponsor, quite a few community forums. We've, I think tonight is, like the fourth listening session around the opioid epidemic around Philadelphia. The CBH staff participates in, I would say, hundreds of health fairs around Philadelphia, every weekend, and, there's, people sort of dedicated to reach out into the community, provide information. The 24/7 phone number is, promoted, far and wide. And, that's, I think, also been an ongoing commitment, is to reach out to people and create access, throughout the last 20 years.
And one thing I did want to highlight that I don't know that we'll get to on the slides is a program called Journey of Hope. It's another, way that you marry resources. Is the city has obviously been very, very challenged by the homeless and the homeless population, which a high percentage have a mental health or certainly a substance use disorder, and created and expanded the concept of the non-hospital rehab into what was called a Journey of Hope program. So individuals are identified through homeless outreach that the county pays for. They are able to bring somebody in to a rehab program of which they are offering, they help them with, if they are able to engage, which a high percentage have been able to engage, if you can keep them there for a 90-day period. So it's a long-term rehab opportunity, and it then allows the person to get Medicaid enrolled. Then we pick up the payment as a rehab, and then at the end of their experience, if they are able, we are able to blend and offer them a permanent supported housing, which is funded through a HUD or some type of Section 8 housing, and then we pay for the treatment costs that can help support them staying.
And we commit to a year of case management once they're in their independent living.
So it's a way to marry all those pieces of the puzzle, basically, to really give somebody a much more a significant opportunity and chance to have a permanent housing option with supports.
Wonderful. We can wrap up, I believe, and go ahead, and we have a few more slides left. We have 10 minutes left, and then we'll wrap up.
So I think we can kind of go, we'll try to go maybe more quickly through these, and I think the slides then will be made available. But this is really just to highlight the upside. So, it's 20 years later, and as Marvin points out, we still have bumps along the way, as you do with any program. But we really feel as if there has been a tremendous impact in the community. I mean, one of the things that I think is a hallmark of the program in Philadelphia is the fact that we've extended our reach into all, really throughout the city and through all the human services. So we have staff that actually sit in juvenile court. We have staff that are really connected to this homeless initiative. We have staff that are connected to child welfare. We have staff that are connected to health centers here in the city. And it's been an opportunity to really extend our reach to make sure that we're touching as many individuals as possible. We increased the access. 20 years ago, we were serving 48,000 folks, and we're now at 113,000 in 2015, and we'll be far exceeding that in 2016 as we wrap up the year. We created a performance and quality monitoring system that is P for P, and we can comment at least on that. And we definitely stabilized the Medicaid funding. We have reinvested about $350 million back into the city. And so, that was really, that is one, again, another hallmark of what's been an opportunity here. If you want to go to the next slide, just to highlight P for P. I guess we're doing the key initiatives, sorry. These are, again, things that we think are some of the real highlights of the program. Been a huge investment into evidence-based practices, actually created a center around evidence-based practices. One of the things we always like to reinforce that even though there is a carve-out, we have a lot of physical health, behavioral health collaboration, and a lot of opportunity to do integration and get good outcomes. So it really isn't a matter of having it under the health plan that a carve-out really can get you the same kinds of outcomes. And then we're doing a significant amount of work around children's services, and I already highlighted the supported housing. And then just to highlight in the next slide, P for P, Dr. Evans, who's the commissioner here, really felt it was important to try to develop an incentive program, and we do it by level of care. So for each level of care, our team worked with providers in identifying outcomes or performance expectations. If there was a HEDIS measure or a national measure that could be the benchmark, we utilized that. If not, really looked at opportunities, and that includes all of the substance use services like non-hospital rehab, etc. I don't believe it includes detox currently. But it is a one-time payment that go to agencies, and as you can see, it's been a pretty substantial investment. It does depend on how much money we have at the end of the year, about what level of funding it is, but it is a really substantial amount of money that's available to agencies.
Which would not have been available, in the prior system.
The next two slides really, and Marvin can comment, are about examples of what we see has happened as a result of the...
Right. So some of the, our metrics were, follow-up after discharge for some priority populations. The first slide, 30, is looking at women with children. We have 7 residential programs that take, a woman and her up to 2 or 3 kids, depending on the facility. And, you can see, successive improvement over the years with the follow-up rate. If you turn the page and you look at 31, that's the Journey of Hope program that is the collaboration that Joan was just talking about a couple of minutes ago, which is actually a constellation of 6 programs targeting people who meet the criteria for chronic homelessness under the federal definition. These are people who've been out on the street for years. The county funds outreach teams 7 days a week, and that is the avenue into these programs, which are licensed as long-term drug and alcohol residential programs. And one of the things that we had to do was to change the normal paradigm of the way these residential programs were working. Traditionally, when you were, your urines were hot, when you're in the program, a lot of programs were kicking you out or they were sanctioning you. We started to see this as just a symptom of the disease and changed the way these programs operated, and specifically recruited programs that were going to be more receptive to working with a very debilitated population out in the street for years, and kind of modifying their approach so that retention, life skills, case management, and the follow-up rates for people who are then discharged into independent living with ongoing case management has also improved over the years. So those are kind of tangible metrics.
Given the time, Liz, maybe that should be the last slide.
It should be. It should be. I would like to move. Don't we have the link? Just to put the links up at the end.
Sure.
There we go. There you go. These are links that you can connect to additional resources. The Community Behavioral Health website has extensive information about, there's provider manual, there's credentialing examples. Much of the quality assurance information is on these sites. So I hope everyone goes to these sites and uses them. I want to thank you both for presenting today. It's very informative, and I hope in 20 years that we can be doing the same presentation in California. And I want to congratulate you on your 20-year anniversary. It's very exciting. Thank you very much.
Thanks for the opportunity.
And that will conclude our presentation today. This will all be sent to attendees by email within a week, in addition to being on the site, on the CIBHS site. So thank you all, and have a great rest of your day.